the lead-off talk. Our topic for today is practice guideline updates for the cardiac anesthesiologist. I have no financial disclosures or conflicts of interest to report. I have been active in this area for a number of years, and as such, am a big fan of these types of documents, particularly for their educational value. CPGs in the arena of cardiac surgery have been published by a number of prominent organizations. The SCA has partnered with many of them to provide input and disseminate information to our members. In preparing this talk, I searched for recent CPGs in this area, but quickly realized how few there were and how many other hybrid documents presented information previously reserved for formal CPGs. The growth of other formats has been driven by the recognized limitations of CPGs. First and foremost are their great expense. Some guidelines can end up costing over $250,000 to complete. Guidelines have evolved over time from the early 1990s when the first AHA CPG on pacemakers was published. Methods to improve their academic rigor have evolved, along with ways to promote readability and dissemination of content to a wide range of care providers. We don't have time to dwell on methodology since first and foremost I want to cover educational content, but I've listed here several formats that I term skinny guidelines. Some of these are quite new within the last year or two, and you will certainly see more of them in the future. We'll also touch briefly on appropriate use criteria that the American College of Cardiology has been quite active in developing and promoting. Before we jump into the actual material, I want to alert you to an exciting new development, several years in the making, that is now just entering the spotlight at this meeting. The SCA, along with representation from EACTA, has developed what are termed Clinical Practice Improvement Advisories. These are written by a working group of SCA members from academia and private practice with the goal of fostering information from multiple guidelines on a particular topic using literature synthesis, member consensus strategies, and graphical or other clinical tools at the point of care. Initial documents on perioperative atrial fibrillation and blood product management are under peer review at this time. We'll touch briefly on atrial fibrillation in this presentation. However, I encourage you to attend the dedicated sessions on them at this meeting. Let's get to some specific material I was impressed with when I was reviewing the literature. My choice of publications is somewhat subjective, with a bias to my particular practice setting, but I've included in your reference list other recent publications that could have been easily discussed as well. To stay within the schedule of this session, I've had to skip over a few of the guidelines presented in your handout. The first document is an STS, Expert Consensus Statement, that covers the resuscitation of patients who arrest after cardiac surgery, an event that is one of the worst nightmares for an OR team, but one that if managed skillfully can have a successful outcome. It appears that the impetus for this document was an absence of any consideration of this topic in the 2015 AHA ECC CPR updates, while it was covered in the simultaneously published European guidelines. The processes covered aren't rocket science, but the document does a great job synthesizing information and presenting it graphically as well. Cardiac arrest after cardiac surgery is a low-frequency event, but one with the potential for substantial morbidity and mortality. The most common etiologies, as you are likely aware, are ischemia and bleeding. This particular protocol, with its emphasis on early resternotomy, is recommended all the way until postoperative day 10. The major recommendations are that external cardiac CPR in this setting can be dangerous, with the potential for cardiac laceration or evulsion of grafts. They advocate that emergency resternotomy be performed as quickly as possible in most situations where return to spontaneous circulation is not obtained rapidly. The group deviates from AHA ECC guidelines regarding the number of attempts at defibrillation in the CPR sequence. In contrast to the single shock recommended by AHA, they recommend the use of up to 3 sequential defibrillation attempts without CPR in between. Synthesis of results from 15 publications suggests that average success rates decline dramatically from the first to third shock. Thus, the low rate of success by the time of a third shock mandates